coming. Little group, week 5 is always crazy at the school. You guys got infectious, so I really appreciate this. So anyway, talking today about Neuro Chest, which is kind of my little custom design I sent from Neuro Chest and Functional Neurology, and this was the best thing I could come up with. So let's get into it. So I'm super passionate about upper cervical, and I'm passionate about functional neurology, but they're completely opposite in a lot of ways, right? So functional neurology is really allopathic. Like, let's break the system down into a machine, find what part's broken, and then fix it. Whereas upper cervical is above, down, inside out bialism, right? So they're completely opposite ideas. And for months, I was trying to struggle to combine the two. I didn't really know how they would work together. But I knew that I was interested in both, and I was going to keep learning about both until I figured it out. So I was really wondering, bialism versus allopathy, upper cervical versus functional neurology, whereas both come about completely different ways of solving any problem. Completely opposite. And then lastly, I'm saying, well, in upper cervical world, the atlas afferentation is the worst thing possible for somebody, right? And we talked about that last quarter, but in neurology, devastating brain hemisphericity, a brain imbalance is the worst thing that can happen to anybody. So they're, again, two different problems that they're both trying to fix in two different ways. So I kind of thought about this for a couple months, and then I finally had an epiphany. So I had decided to go on this mission trip to El Salvador with my roommates and everybody here, and I was wondering what techniques to do, and I'm like, I'm going to do full spine, and I'm like, well, I might as well do upper cervical since that's my thing. I'm like, well, I might as well use neurology. And so this is my idea. So I kind of wrote this out on a piece of paper. I'm going to read it to you guys, but this was my original draft. So there exists a philosophical split in the chiropractic profession. Upper cervical follows a vitalistic, above, down, inside out philosophy that removing brainstem compression will help for natural body healing. But neurology more operates about the idea that the allopathic model of finding subjective flaws in neural output, and we appropriately input the CNS and get those nuclei back online. So this technique is really designed at uniting both of them into a powerful one-time adjustment, mainly for mission trips, which is where I was going. So Neuro Chest is also known as the Palmer-specific technique, and it's recognized as one of the most powerful adjustments. And that's why you always hear people get Neuro Chest, it's a burst of light, and they're just blown off their feet. And you don't really hear that with so many other adjustments all the time. And it's really a quick input to the posterior arch of the atlas along the occipital condyle. It's meant to restore movement to the atlanto-occipital joints. Thermography is utilized to monitor the subluxation, since a properly aligned moving atlas will alleviate autonomic imbalances. However, there exist subtle flaws within the analysis that may lead to negative outcomes. Aberrant anatomy can flaw in X-ray analysis, while the metabolically challenged may have difficulty integrating the magnitude of afferentation. I don't know if you guys have heard about this at all, but sometimes it's kind of hard to read an X-ray. You can't exactly tell laterality. Also, there's stories of people not doing so hot after their knee chest adjustments. And that really is because it's so much input that you have to be healthy enough to handle that much input. So that's not everybody though. So functional neurology is a detailed and specific approach to observe signs of neural degeneration and choose tailored therapies to input them. A basic premise of functional neurology is hemisphericity. That is, a brain imbalance will cause aberrant physiology. So you use contralateral stimulation to bring the rate of firing of neural integration to near balance levels. The problem with functional neurology is that typically patients need multiple visits and a complex workup to efficiently treat people. So like I was saying, this is completely opposite than upper cervical. Upper cervical says everything is this. But functional neurology might be like, this person needs to spin while looking to the right to input this part of their brain, okay? So on mission trips, the chiropractor really only has one chance with each patient to really give them their input, give them their gift, and then they never see the patient again. So it's almost every chiropractor agrees that the atlas is the most important adjustment. Regardless of upper cervical or not, almost everybody agrees that atlas is the most important bone to set correctly. However, it is the understanding of nearly every neurologist that inputting the brain on the correct side is of paramount importance. This technique combines the neurological analysis, functional neurology, with the powerful input of Neuro Chest to deliver a one-time adjustment with maximum innate. And it's kind of like that maximum innate, whatever that means. So that was basically my initial brainstorm of how can we start combining these two into one powerful thing. So we got to regress a little bit about my background with Neuro Chest. when I got to Life West, I didn't know what upper cervical was, and by second quarter, I was deeply committed to it. So I just wanted to pick a technique and start working on it. So I chose knee chest, and I started self-teaching myself. Like every day, I was reaching out to upper porters to give me instructions on how to position my body, how to position the patient, what the adjustment means, and how it affects them. And so I was really studious about knee chest for about the next 9, 11 months, right? And it was really around quarter 5 that I started getting interested in NUCA and drifted off knee chest a little bit. But I really had this like deep underlying passion for knee chest that was born really early here at Life West. So I bought a speeder board, I started doing drills almost every single day, and I was just working really hard until I got into NUCA. So really when I decided that I was gonna go on this trip and I was gonna do upper cervical, I got way back into the knee chest. I bought a table off Stephanie Williams. It was like $250, it's a great little table. And I already had a speeder board. I just started doing drills every single day. I was asking everybody I could for help. And I mean, I was reaching out to Ian, Khalsa, Dill. I spent like every other afternoon in Khalsa's office, Q&Ing him. So I really spent 3 months preparing my body as best I could to do a knee chest adjustment. So for this adjustment, I was really just going to do ASL or ASR. I wasn't going to do rotation. And laterality really is the big objective in knee chest, right? You're going to look at the x-ray, and if you have a right atlas, that's going to be the main thing you're trying to correct, is get that sucker back into the center, to get those joints moving right. So that's a little bit about my background with knee chest. Now, functional neurology, I kind of got into that about a year ago when Carrot came to Life West, and he like blew my mind with his talk. I don't know if you guys got to see that, but he was doing some miracle cases, and I kind of realized if I was going to be a doctor of the nervous system, I needed to learn as much about the nervous system as I can. So I kind of just jumped into this neurology program, and I really committed myself to the neurology. So I would study the neuro outside of school more than I would study for classes in school. And so now I've done 9 of the 20 modules, so I'm almost halfway through the neurology. But a big idea of neurology is hemisphericity. So here's some smart talk that I put together. Fixation of spine can cause changes in gain in paravertebral muscles and disafferentation from joint castles. This will eventually lead to diastasis of the cerebral cortex, which will result in transneural degeneration of conjumental reticular formation. So if we want to go back to English, what it means is the entire concept of disafferentation. It applies everything. When you're not moving, you're not generating input to your brain, right? And the brain is super reliant on that input from the spine. So what happens is you're going to have an imbalance in the functioning of each half of your brain. Whereas this is your right brain, this is your left brain. The right brain might get a little bit stronger, and it can actually overpower and inhibit the left brain. So in neurology world, what they want to do is they want to balance these two levels of the brain. That's the hemisphericity. And that's their main objective at reducing, is hemisphericity. And what happens is when you have a hemispheric lesion, your brain's not working so well on the side, it expresses itself. So in your brainstem, you've got this center called the PMRF, right? Pontomedullary reticular formation. It controls 4 different functions in its lateral side of the body. That's going to be muscle tone, sympathetic balance, and pain inhibition, right? So when you have a hemisphericity, you can actually tell which side it's on by looking at these 4 factors coming out of the PMRF. And what you want to do is, let's say you have a decreased left brain, you want to be adjusting them on the right side. It inputs the left brain and brings it back to balance. So that's why chiropractic comes into neurology, and that's what the functional neurology guys do. That's the main focus of what they do. So really what this means is, what's more important, laterality or hemisphericity? Upper cervical says laterality, neurology says hemisphericity. What I came to the conclusion was that they're both equally important. You want to be able to reduce both to give the patient the maximum benefit. So in a perfect world, what would always happen is you would have a right atlas and a left hemisphericity, whereas you could adjust them on the right side and fix that atlas, but also bring that brain back up. So that's a perfect world, or vice versa, a left atlas with a right hemisphericity. And so what I started wondering was if the upper cervical subluxation is like the detriment of all mankind, is the cause of all disease, as BJ called it, could the atlas be causing the hemisphericity? Is there a causation between the two? So here we go. This is my theory right now. Can atlas laterality causation factor brain hemisphericity? So let's take a look at it. So these are your suboccipital muscles, and these are the most densely packed with mechanoreceptors in your entire body, like by far and none. These have more mechanoreceptors. So let's say you have a right atlas. The atlas has moved this direction, right? What it means is that this rectus is going to be stretched more, and this rectus is going to be stretched more on this side. So what happens is as these are further stretched, they're closer to firing all the time. Those muscle spindles react, they fire to stretch. And since these are further stretched just passively, they're going to be firing off more, okay? So as we have a right atlas and these are firing more, they're firing up and feeding the right brain more. So what it means is that this left brain will be down, this right brain will go up with a right atlas. Now this is kind of my theory that I started coming up with. I don't know if it's accurate, it's a theory, we need to prove it. I talked to Carlson quite a bit about this last quarter, and I'll probably be going into research with him in the future to see if there is a correlation between the two. But if there is a correlation between the two, then it really means that all of the functional neurology people have to become upper cervical people, because the main focus of what they're trying to fix is being caused by the same thing that we're trying to fix in the upper cervical world. So I'm going to go into research to look for a correlation between the two. But this is the theory that I went out there to try and see or validate. So this was my initial workup. Was step one, are they even subluxated? I was going to do a prone leg check, or I'm sorry, supine leg check, that's wrong. Because in orthogonal world, if the legs are uneven, it means they have an entire body imbalance because their atlas is out. That's how NUCA and advanced orthogonal work. And then in knee chest world, glare, toggle, they all do thermography. So I didn't have a thermography unit. I was going to get one of those little pen lights, the infrared scanners, but I didn't get one in time. So I actually went out there without that. I did only supine leg checks. That's my bad. The next thing I was looking for was laterality. So I was going to look at both factors. Even though I was using the hemisphericity as my side, my dominant side, so I was mainly adjusting on my brain hemisphericity findings, I was going to look for laterality to see if there was a correlation out there in the field. So for that, I did lateral flexion, head tilt, atlas challenge, and motion palpation. Were going to be my 4 laterality findings. And I would try and get a correlation between the two and have a guess at what their laterality was. And then lastly, for my hemisphericity, I had a whole slew of different neurology findings. And I could explain these to you, but it would take forever, so we're just going to kind of look at how it plays out. But the truth is, this didn't go the way I planned on it going, because there's a language barrier, and you're trying to see 250 people a day. So this kind of got altered, and I modified it as I went. So here we are. So I start with a supine leg check on every single patient. Now, I was actually borrowing tables from people because all I had was a little knee chest and people didn't really want to lay on the floor. So I borrowed the tables when I could, and I would do the supine leg check. And when I had them down there, I go and I do an atlas challenge just for the hell of it. Now, I think atlas challenge kind of gets a little bit of grief here at school, as in like people aren't sure about it, but when you think about applied kinesiology, their muscle testing is really along the same thing. So that muscle will go weak if you push the bone in the wrong direction. And the same thing is happening here. If you push the atlas in the right direction, it's going to have a positive net effect on the muscles of the entire spine. That's why the legs go even. So I did atlas challenge on almost everybody, and that was a really good window for me. I get in there and do palpation myself, see what I felt. Now, typically in upper cervical world, palpation is like the least effective measure to predict laterality, but it was worth a shot, right? It was just another window of what we had in the field available at the time. If I could have taken x-rays of everybody, I would have loved to. After that, I bring them up, and if they were subluxated, I bring them up and sit them in the chair. And we got into visualization, so this is actually really important. Ignore my anterior head carriage there. But a big part of brain hemisphericity is, let's say they got a decreased right brain. They're going to have increased tone in the anterior muscles above T6 and increased tone in the posterior muscles above T6. So what happens is with a right brain, they kind of, this arm comes forward and this leg comes back a little bit. So it's actually able to look at their shoulder. You can see that this one was a little bit anterior to this one. And that was a window into hemisphericity. So I saw a front left shoulder, and I think, okay, maybe the left brain is not functioning as well. We looked at pupil size. That was actually a really important in neurology world, is you want the pupils to be even. Because if the pupils are uneven, it means they have more sympathetics on this side or more parasympathetics on this side. So it's a really good window into brain hemisphericity. So typically, the larger pupil is going to be the side of decreased brain. There's a ton of exceptions to that rule, but it's a good general rule. And with all of neurology, it's not one finding means one thing. Oh, this pupil is big, this brain is down. You got to do a whole bunch of tests and start making a correlation to build a general picture. So it's the same thing with laterality. So I was looking at pupil size and then lastly head tilt, where they be kind of stuck like this, and in upper cervical world, the right head tilt means right atlas. And head tilt is really all that most knee chest guys go off of on these mission trips. They'll just be looking at head tilt. And I just think it's a little, there's more that we can be looking at than just that. So that was my last laterality finding right there. So I got up into finger DDKs, and that's really where you just do piano fingers as fast as you can, and you see if one side has broken movements or slower movements. And it's a window into lateral cerebellum, so the farthest corner of the cerebellum. So in a decreased right brain, you're going to have a decreased left cerebellum typically. So I was looking at cerebellar findings, trying to correlate those. And I got into pronation, supination DDK, so I'd have them switch like this. And it was really easy. It was just like copia mis movimentos, right? Copy my movements, and I'd do it, and they would do it. So I was able to run through these cerebellar tests real quickly. So I got into perfusion testing after that. I'd have them put out their hands, I'd take a look at it. Now in a decreased right brain, you're going to have increased sympathetics on the right side of the body compared to the left. So since sympathetics control blood flow, it means that if I test their perfusion by pinching both their fingernails, whichever one fills up slower with blood means that has higher sympathetic tone on that side. So I would do that on each of the fingers and kind of look to see if I could get a window into sympathetics. I have them flip their hands, I look at skin tone, so the whiter hand is going to have less blood nick, it's going to have higher sympathetic tone. The redder hand is going to have more blood flow into it because that will have less sympathetic. Another window is the hemisphericity. You check sweat. One hand might be sweatier than the other. That again is controlled by sympathetics. And then, yeah, capillary refill. So simple, like similar that I was doing on the fingertips, I do it on the palm of the hands. Look for capillary refill. Last, I got into cardinal fields of gaze. So mira mi dedo con sus ojos, look at my finger with your eyes, and I kind of bring them both sides. Now in neurology, when they're pursuing, it's a parietal lobe, it's an ipsilateral parietal lobe. So as I would bring my finger here, I could see the quality of those movements and tell how well this brain was working compared to this. So I bring them through all fields of gaze, looking at cerebellum, looking at their general responses. And that, again, gave me another window into the hemisphericity. So it was really at this point that I had enough information. I had a bunch of guesses on laterality, I'd have a bunch of guesses on hemisphericity, and I'd see how they correlated. And hopefully, in about 70% of my cases actually, there was a correlation I was looking for. I was seeing left laterality with a right hemisphericity, and I'd go ahead, or vice versa. So 70% isn't great, it's not what I expected, but at the same time, I'm guessing on laterality. I don't have x-rays to prove anything, so it's interesting. So at that point, I get in there one more time, I palpate. Similar to the Atlas challenge, you can push and see how the feet react. You can push on each side of the Atlas, see how the eyes react. And if you push in the wrong direction and the eyes get huge, they're having a sympathetic reaction, they don't like their Atlas going that way. It's kind of a little test I developed along the road, and I saw how that played out for me. So at that point, I'm ready to just get them on the table. Again, go on my posture. But this is Stephanie's table. I had a little foot piece right there, and it was actually really great at that 11-degree angle. So the good thing about the 11-degree angle in knee chest is that occipital condyles are kind of at an 11-degree angle, 12 degrees. So when they're on their side at that angle, that joint is straight up in the air. So when you go in for that adjustment, you're going straight down towards the floor and you share that joint back into place. So that's kind of the reasoning behind the slant of the knee chest table. I get them on there, I have them relax, find my contact point, posterior arch. I was really meticulous about this point. Get my contact on there, boom, blow them up. So it was really interesting. Now, in neurology world, we never want to take somebody from 0 to 100 miles an hour. So I was actually doing some thoracics on here, and it actually worked really nicely on the knee chest table because their hips kind of rotated this way and it opened up. so I could set a thoracic real easily. And just by setting that thoracic beforehand on some people, kind of light up their cerebellum, get their brain running a little bit higher, ready to handle the big input from the knee chest. And tried a couple different things. Now I was really there by myself. I was the only upper cervical dude on the trip. So I was kind of playing around, not playing around, but finding what worked for me and what didn't work for me. And I really found that the Hydroform was a little bit too broad of a contact, especially on the kids. So I was going with my 5th metacarpal right there, and that's what you see is right there. So that was really great. Now my favorite case of the week, or the whole week, was this old lady. She came in with a whole purse full of drugs. She had headaches like crazy. And headaches are like an instant giveaway that they got an atlas subluxation. Anybody with a good atlas should never have headaches for any reason. So I knew right away that she was ready to go. I found her hemisphericity, her laterality, and her atlas set like really hard, like clump, you felt it. And she gets up, she was crying, she was thanking me in Spanish, and it was great. And this was the last part of my entire procedure, was kind of sitting on the table, looking in their eyes and seeing if they were having a sympathetic reaction or a parasympathetic reaction from the adjustment. Trying to get an idea of whether their neurology was accepting and appreciating the input or not. So it was kind of interesting. This guy was our bus driver. He was actually my second person that I adjusted the whole trip. And his atlas set harder than anybody else's the entire trip. It was just boom, huge clump. And after he went, he slept in the van for like 3 hours right after this adjustment. And it's kind of neat, like you hear these stories about people going and their nervous system's kind of resetting from the knee chest. He had needed that his whole life. So that was a pretty profound adjustment for him. I really liked that one. And then lots of kids, lots and lots and lots of kids on this trip. So I probably saw 250 people altogether. Probably saw at least 100 of them were kids. There's all of them doing hard Pisces. This guy was a little orphan that followed us around for 2 days, and I was having him do adjustments on people. Like I put his hands on him and adjust them through his hand, and he'd freak out laughing. So it was a really awesome experience. This was spinal missions. We went to El Salvador for a week. I can't highly recommend this trip high enough to everybody here, especially for us going into clinic. It was really good for us to get our hands on people, get used to seeing numbers and helping people. So this is spinal missions. It was just an incredible experience. So that's basically the premise of what Neuro Chest is. I have to go into research and try and see if there really is a correlation between atlas laterality and brain hemisphericity, which was really my objective here, was how can we adjust a piece of neurology people and a piece of the upper cervical people. And it was a really incredible experience. So that's about it. Thank you guys.